Good afternoon, all. Mistress Naomi Jeremiah, Permanent Secretary, Ministry of Mental Health, Wellness and Religious Affairs. Mr. Josh Hector, Director of Mental Health and Substance Abuse, Ministry of Health, Wellness and Wellness and Religious Affairs. Dr. Teralyn Malcolm, our advisor from PAHO on non-communicable diseases, who I believe is online with us. Dr. Samatra and Jasmine, our PAHO consultants for our mental health policy and suicide action plan. I'm not seeing Mr. Hewitt, but our PAHO country representative, Mr. Ronald Hewitt, sorry. Dr. Chaitan, I believe, has left us. Our Senior Administrative Officer, Father Edward Mark. Representatives from the Ministry of Social Development, Housing and Gender Affairs. Representatives from the Ministry of Youth and Sports. Staff within the Ministry of Mental Health, Wellness and Religious Affairs. Good afternoon to you all. The Ministry of Mental Health, Wellness and Religious Affairs take this opportunity to thank you for agreeing to participate in our continuation of our stakeholders' engagement as it relates to our mental health policy and suicide action plan. Your contribution today is of great value, it's of great importance as we finalize and the final steps towards approving our policy for mental health and our suicide action plan. At this time, to bless this evening's activities, I will call Father Mark to bless us.
Thank you very much, Senior Planner. Good afternoon, all. Let's bow our heads in prayer. Gracious and ever-living God, we are grateful to you for life, for health, for strength. We are grateful to you, dear Lord, for initiative. We are grateful to you, dear Lord, for collaboration. We offer unto you this consultation, dear Lord, as we continue to work together as it relates to suicide prevention, mental health, and the general well-being of our nation. We pray, O God, that as we seek to share ideas, as we seek also to find a collaborative route to work together so that we can build a stronger nation mentally. May you guide our discussions in this consultation. And may we, as we work towards having our policy properly legislated, and of course our Mental Health Act reviewed, we ask for the guidance of the Holy Spirit as we seek to continue discussions. In Jesus' name we pray. Amen.
Thank you, Father Mark. To welcome us all this afternoon, I call to the podium Mrs. Naomi Jeremiah, our Permanent Secretary within the Ministry of Mental Health. She will do a welcome and brief remarks.
Thank you very much, Madam Moderator. A pleasant good afternoon to everyone. It's indeed a pleasure to have each and every one of you here this afternoon. Your voices to this consultation today is very rewarding and enriching. What you have to say today to us here at the Ministry of Mental Health is enriching. I'd like to stand on the protocol so enrichingly established by our moderator this afternoon. However, I'd like to acknowledge with me my Health Services Administrator on the head table and the Director of Mental Health and Substance Use. I also like to acknowledge Ms. Jasmine here with us today from the PAHO team, our main consultant, together with Dr. Samata, who is at a meeting now. And we have Dr. Malcolm and others online. I welcome you. Today, we at our final leg. You know when you're running a relay The batter starts with very much heat. Then you have the middle batter that goes with it. And then the final leg. That is where you are here today, the final leg to reach home to the finish line. And at the finish line, I would like us to see a transformed Grenada where our statistics and suicide will be reduced and we will reach to the point where we have 0 suicide attempts or even completed suicide in Grenada. I want us to clap to that. We want no suicide in our island. 0. 0. That is what we're working to. But I want you to see yourself as a key player in that relay. Your voices are very much needed. Your collaboration and your input is needed on the front. And that's why we have you here today. We want to hear from you. We want to hear your voices. We want to hear stories. We know that our country at this time, we're mourning the loss of 2 young persons recently. You know, and it hurts my heart deeply. And I look back and I said, where have the system failed? Where we have failed. As we grappling with that, we have a adolescent and child health clinic that is rising. From my data, at the beginning of 2025, we had 150 cases on our mental health adolescent and child clinic. Now, at the end of 2025, I'm going to review the data for 2026, and I show it is growing. Now, when I look at 2025, we had 300 at the end of 2025, December. So the clinic has doubled for adolescents and children. And we had, because of that, our ministries make decisions based on data. So because of the data, the evidence are there. We had done a pie chart and a bar chart to analyze which of the areas that these young people are need of mental support. And we look at the schools and we realize St. Andrews, St. George's. These are the hot spots. We know it. We know where the hot spots are because we did analyze our data. And that is why we have been trying to work with Ministry of Education to implement what is called a Stronger Mind, Stronger School program. And that is a program that is very intricate in that we meet with the parents, the teachers, the student. We have a very renowned counselor for child clinic, Dr. Francia. She's a Cuban and she's well equipped and trained to manage that program. So here we are continuing to collaborate with them to ensure that the commencement of that. And come end of this month, we are going to be launching our suicide prevention hotline. And it's a response hotline, which will give the clients referral pathways. Mr. Hector will speak more to it later on, but I'm just telling you what is happening now. But I am indeed happy to have you here. And I know we're going to have our enriching discussion and dialogue together. So welcome, and may you be blessed with our presence here. Thank you.
Thank you, P.S. Jeremiah. I think that was your motivating speech for to be able to start formulating your thoughts as you make your contribution towards the policy. So this evening we are here, as we say, to discuss the mental health policy and for us to make our final suggestions and recommendations. And to put this in focus, we call the Director of Mental Health, Mr. Josh Hector, to give us an overview.
Thank you, Ms. St. Paul, and good afternoon to everyone. So we have with us distinguished representatives from the Ministries of Youth and Sport and from Social Development, and we wish to welcome you to this consultation. For those of you who have been to a consultation before, welcome back. And for those of you who are here for the first time, welcome officially. We wish to sincerely thank you all for joining us for this consultation process for Grenada's national mental health policy and action plan with specific focus on suicide prevention and strengthening our national health systems. Today's engagement builds on valuable contributions made during past consultations and reflects our collective commitment to developing a more coordinated, inclusive, and responsive approach to mental health and well-being in Grenada. So as we move forward to finalizing this policy, we focus on a few key priorities. Number one, improving access to quality mental health services. Number two, strengthening prevention and early intervention initiatives. Number three, enhancing mental health surveillance systems. And four, improving national coordination around suicide prevention and psychosocial support. Why the Ministries of Education and, no, sorry, not education, sorry, we had education this morning. The Ministries of Social Development and Youth and Sport, why are you important? Young people and vulnerable populations are often significantly impacted by mental health challenges, and the systems represented here today play a critical role in early identification, support, intervention, family engagement, social protection, youth development, and the promotion of resilience across our communities. Importantly, when this is concluded or completed, we will also move towards modernizing or updating our mental health legislation, which happens to be just about 130 years old, if I'm correct. It's very important for us to add legislator to ensure that we don't just have policy, but we have legislation to guide what we do, how we do. We remain deeply appreciative of your continued support, and we also thank PAHO for their continued support, as well as our colleagues from Center for Mental Health and Law in India. And as you are here today, your contributions are extremely valuable. So when the policy is being presented, you may identify some gaps based on your perspective. Those gaps are actually opportunities for you to say, to slip your hand up during the questions and comment section and say, we can include X, Y, or Z. Once we contribute enough, we are going to have a very robust engagement today, and we will leave strengthening the final mental health policy that we are seeking to conclude. So thank you for your presence, and thank you in advance for your contributions.
Thank you, Mr. Hector. And this brings us to the end of our short formal part of this evening's session. We just want to remind you, if you haven't seen it yet, of our public consultations that are going to be taking place on Wednesday and Friday. Wednesday at 6:30 p.m., we'll have our public consultations at the Luke Cinema, Grenville. So we're asking that you please share the information, pass the word on, so that persons can come out and share their concerns, their suggestions, recommendations as we build on this policy. And Friday, 6:30 again, at Agape Ministries, River Road, we would have the consultation, public consultation for St. George's. So please share the information. At this time, I invite our facilitator for this evening, Ms. Jasmine, to come to the podium, and she would do a presentation for us, and then we go into discussions. Thank you.
Afternoon. Just going to try and share my screen. Just to get a sense of people in the room, can I just request you to say your name and your designation and your ministry, just so we know who all are here? I know you all know each other. Unfortunately, I don't. Maybe I'll just pass the mic around.
Good afternoon, everyone. I am Samuel St. Bernard, Senior Planning Officer in the Ministry of Social Development.
Good afternoon, everyone. I'm Vonnie James with the Ministry of Youth, Social Care Officer.
I am Kizzy Matthew Clarence, Head of Psychosocial Support, Ministry of Social Development.
Petra Louison, Public Relations Officer in the Ministry of Social and Community Development, Housing and Gender Affairs.
Good afternoon, everyone. My name is Juliana Mitchell Lewis. I'm Senior Administrative Officer in the Ministry of Youth and Sport.
Good afternoon, everyone. My name is Adana Francis John, Project Officer within the Ministry of Youth and Sports.
Good afternoon. I am Lanisha Joseph. I am the head of the Social Care Unit, Ministry of Youth and Sports.
Hi, everyone. Pauline Richmond Mitchell, Senior Supervisor in the Ministry of Youth and Sports.
Good afternoon, everyone. Salisha Ruben, Project Officer, the Ministry of Youth and Sports.
Not missed anyone. Okay. I should introduce myself. Hi, I'm Jasmine. My colleague Soumitra is taking a call. He had to be pulled into another meeting, so he'll be joining us shortly. We've been working with the Ministry of Mental Health to try and work a roadmap, really, by the mental health policy and a plan. And some of you we've engaged in different ways. I definitely remember meeting you, Kizzy. So thank you for being here. The purpose, like we said, is essentially giving you an update of how far we have reached through our meetings and our consultations of where is the roadmap heading for mental health policy, as well as a broad plan. The idea of meeting you at this stage is to understand, are we missing something? Is there any glaring gaps or scope for improvement, or anything that we should be adding? Because this will become the roadmap for the next few years. So what are the opportunities that we have where we can collaborate? So the plan for today is I'll just walk you through the presentation for how far we've reached. Then we'll pause for some questions, comments, discussions. There is a notepad, I think, with you. So if you have any question, please keep noting it down. It's just easier to go in the flow and just walk you through everything that's there and then open it up for conversation. So with that, I'll get started. All good, right? So just to set the context, of course, Government of Grenada is prioritizing mental health action. What I'm hearing is anyway, it's become the need of the hour to look at mental health and suicide prevention. And in the Caribbean in general, we've also had the privilege of working with many other countries who are also reforming their mental health law as well as the policy. So clearly there is a momentum, there is a commitment to change. Having said that, we also recognize that there is stigma, there is discrimination when it comes to mental health, and we're all globally actually quite under-resourced when it comes to mental health. But we have a committed national strategy to address mental health prevention, promotion, treatment, care, and a whole of life sort of approach. It was, of course, developed in consultation with the Ministry of Mental Health, but we've had several conversations with each of your departments as well. And now this is more sharing update and progress. Sorry. Okay, so the purpose, I think like Josh also said in his opening remarks, it's to improve access to quality mental health care. It's to promote mental health well-being and protect of the rights of people who actually have mental health conditions. The scope of the work, of course, is going to span all across the programs that are running by the ministry, but also programs that are being run in collaboration with the Ministry of Mental Health, as well as your own programs, because we've realized that there's a lot of overlap and mutual pathways of integration as well. The broad vision, of course, is that we will be a country where mental health is valued, promoted, protected, where people with mental health conditions are able to exercise their full rights on an equal basis with others, and they receive high quality, holistic, and community-based care. So you'll see that there is a bit of a transition away from looking at mental health just as a clinical sort of service, but actually look at more holistic ways in which all of us can contribute to better mental health and well-being. Of course, the policy statement has been taken from the work that has already been happening and leverage the momentum that already exists for looking at the National Strategic Plan, where we are saying health is important to us as the government of Grenada. Broadly, some of the keywords we wanted to get your attention to is looking at promotion and protection of mental health across the lifespan, which is where a lot of your work will intersect with mental health. It's looking at providing community-based integrated rights-based care. So again, moving away from standalone institutions to actually integrating it within the community spaces. Engaging people with lived experience to be a part of this process of change, and for fostering some level of advocacy and civil society. There are 5 broad areas of focus that have come up through our conversations and consultations. The first one is looking primarily at governance and leadership for mental health. The second one is looking at comprehensive, integrated, community-based care. The third one, which I think will be of most interest to us in the room, is looking at intersectoral collaboration for promotion, prevention of mental disorders, as well as psychosocial rehabilitation. So that's the space which opens up a lot more conversations across our ministries and departments. The fourth one is slightly more standard. It's looking at information systems and research. And the fifth one is looking at more so rights of people who have mental health conditions. So the rest of the presentation, we'll just break up these 5 components and let you get a flavor of what is there. Of course, the detailed document will have a lot more words, an action plan, and a strategy. So the first one is looking at strengthening governance and leadership. As you might be aware, there's been some conversation around the mental health legislation reform in Grenada. The drafting instructions have been prepared. So clearly there is a move away from what was, I think, a much older law, and how do we catch up with the international conventions and conventions that we have signed as a country, which look at the rights of persons with disabilities, which includes psychosocial disabilities. So there has already been some work around the mental health legislation, and that process is ongoing. And one of the pieces of that puzzle is doing the mental health policy and plan. One of the, of course, a clear commitment has come up from the government is to decriminalize suicide attempts. And that is, again, something that is being worked upon within the legislation, and a suicide prevention strategy is also being worked upon. In broad essence, it's looking at building enough systems and structures and processes for doing a rights-based approach towards mental health legislation, decriminalization, mental health policy, and mental health plan. So as you will see that there are some expected outcomes that we've started also listing out, which is saying things like, if we had to change the legislation and decriminalize suicide attempts, that we are making sure all authorities have been established, awareness and education sessions have been conducted. As part of, again, international conventions is increased spending in mental health funding, which typically globally we have seen is the least. So part of the recommendation is to do a minimum 10% of the overall health budget. There's some echo, isn't it? Okay. So part of the commitment is to say that 10% of the overall health budget will be allocated to mental health purposes. Again, the expected outcomes, as you can see, is that there has been an allocation and there is a reorganization of services. The third bit under the governance and leadership is looking at how do we involve people who have lived experience, which means that people who have mental health conditions, how do we get them involved? Not just actually in engaging in policy formulations, but also further on in monitoring and evaluating some of the outcomes. So part of the public consultations and the conversations is to bring up participation from a key group, which is people with lived experience. And the expected outcomes there we've said are things like what we heard is increased in establishing some of these associations, making sure that people are engaged in dialogue on an ongoing basis and not just one event. So that was the governance and leadership. We move to the next strategic area, which is quite focused on this integrated, community-based, holistic, comprehensive mental health care. So what does that look like? Now, according to all of the international conventions, ideally mental health needs to be integrated within all forms of services, especially all general health services. So there is a move and there is a push towards saying that standalone hospitals, which is, say, in our case is the Monge Hospital, should not be the only form of mental health care that is available. So how do we reorient our services to make sure that we're moving away from standalone hospitals to make sure that community-based services are well equipped to do that? So of course, there is going to be a focus and a roadmap towards phase reduction and increase in community-based services. Now that requires a series of steps which we will work towards, and it won't be something that just happens tomorrow. We also know from experience and a lot of data that standalone hospitals also open up space for human rights violations. So part of the reason towards this shift is to make ourselves more equipped with what Grenada services should look like. The expected outcomes there, as you will see, is looking at increased community-based services and looking at community support teams, which already exist, and how do we strengthen them further. The other part of moving towards this community-based integrated services is also looking at integration of acute psychiatric services within general hospitals. So again, if we have to move away from standalone or single tertiary hospitals, what do the other general hospitals need to do, which is make sure provisions are there for inpatient as well as outpatient care at all of our general hospitals across the 6 districts. Expected outcome there is we already used to have this. St. George's would provide acute psychiatric care. So how do we position it back to that? And how do we make sure that the staff is well equipped to address inpatient, outpatient care at all the other hospitals, including Carrico? The next part of looking at the integrated approach is investing in primary care. So what are the kind of services that should be available at primary care services? Looking at evidence-based tools that already exist, which is the WHO MHCAP, quite popularly known. So all the staff will need to actually be able to get trained on it, identify, address, treat, and therefore make adequate referrals to any other kind of services that are required. A huge part of this is around the training. So the expected outcome is looking at, say, a training coordinator for the MHCAP to make sure that all of the training at the primary care level, whether it's nurses, doctors, or any other allied professionals, are they getting trained, but are they getting trained to actually change practice? So not just knowledge-based training, but how do we transition it to supervision and mentorship as well, so that they can feel supported to move forward. The next part is focused more so on suicide prevention services, because that also requires more capacity building. And given that it is a national priority, that there is also a separate suicide prevention plan that is being created. And here I think I only want to get your attention to looking at training primary, secondary, tertiary care services along the lines of suicide prevention. There are evidence-based modules such as the MHCAP that exists that we can implement. Again, expected outcomes is looking at training, but also receiving supervision and mentorship. So that was more training, capacity building, making sure community-based services are available. This one I think is probably more of interest, and I'd like you to just focus on where you think some opportunities for collaboration will exist, where we've had several conversations with different ministries to say, what more could we be doing and what is already happening that needs to get formalized. So this is the intersectoral collaboration. Again, mental health can't be done by just one ministry. It is a cross-cutting issue. All of us are handling it in some way, especially young people are at most impacted and vulnerable groups are most impacted. So how do we make sure that we're capitalizing on this moment where we can put a roadmap in place, where we can be aspirational in what we want to achieve? So the first one that we heard from several people is that there was a technical working group which had been established as part of the MHPSS, which is basically broadly mental health, psychosocial care. Unfortunately, a lot of the times it's become very disaster focused. But what we heard strongly from everyone is that it was an interministerial technical working group that was held by, that needs to be held by the Ministry of Mental Health to make sure that the meetings are happening and there's a terms of agreement in place. But in essence, make sure that we are coordinated in our efforts, that we are not overlapping, we're maximizing the potential that we already have. And the idea of doing the technical working group is that we can align all of our actions to make sure that people are benefiting from the services. So this is something we've heard from quite a few people. As of now, it had lists of health, social development, education, youth and sports, legal affairs, labor. If you think we have missed someone out, you can just keep making notes of this. Then we started looking at different ministries that had suggestions on the collaboration. So more specifically around social development, especially if you're looking at community-based care, there are lots of long-stay patients who are there at Monge, and if they need, and their needs are more social care and more housing rather than medical care. So there needs to be some sort of an alliance with the social development to make sure we are combining our efforts, because work is already being done under housing, under social development. So as of now that we had, what currently exists is that to make sure that we have comprehensive services for their mental health needs as well as their social care needs, there needs to be collaboration with social development. In particular, there was a huge amount of conversation around people who need housing and for people who do not have a home. So how do we try and integrate them back into community-based services, where we said that there is some potential for collaboration there. So how do we set up social care homes, residential facility, keep a specific focus on people who do not have a house? Some of the broad outcomes are looking at increased community-based residential spaces, increased community-based psychosocial programs that are running, increased number of people who can receive even social entitlements, social benefits, including disability benefits, an increased number of people who do not have a home to actually have some residential care available so that they don't have to fall back into an institutional standalone psychiatric hospital. Okay, with that, I'll move to the next one where we had, the morning session was with the Ministry of Education. So we had a detailed conversation about what we had put down and what potential exists. Currently, as we understand that there is a life skills program that's already being run, which covers some bit of mental health and psychosocial care. So leveraging that program is to build alliances to say, how can life skills in young people, how can that play a key role in prevention, promotion, and treatment, making accurate referrals and so on. So this was meant to be a space for collaboration on looking at curriculum, and the suggestions that came in was teacher training. While they're in service, how can we supplement their skills? How can we create protocols for making sure effective referrals are happening, information is circling back? So those were some of the conversations that we had to open up this this piece of work. So we're hoping all of you are kind of keeping your thinking hats on to say what other potentials exist within your ministry to kind of build on that collaboration. In that, the expected outcome, a lot of it was focused on the training. So at least making sure that the programs that exist are being implemented, people are receiving the training, mentorship, supervision, and that the sessions are actually being run. Okay, this was again quite a strong suggestion to say that there are lots of myths around mental health and that's leading to stigma. So there are now evidence-based ways in which you can do a mental health information campaign that can challenge a lot of these myths and improve help-seeking behavior. Part of the most evidence-based strategy around that is increasing contact with people who have a mental health condition or a mental illness. So developing that sort of a campaign, which is national, which is not just once in a year, but actually exists as a repository of information that people can use, so that there are lesser cracks in the system and everyone knows where to access for mental health support. So the expected outcome here are looking at the campaign has been designed, it has been costed, and there are adequate resources that have been put in place. There is an involvement of a different range of stakeholders to make sure that the campaign can run. We had a detailed conversation with the Ministry of Sports, and there it was interesting that there was a whole conversation about using coaches as mental health first aid responders because they are most in touch with young people themselves. So how can they be equipped to understand mental health first aid, simple, easy training, which everyone can use? They highlighted that performance management, especially for athletes, is a particular area of interest. And there was some conversation to say beyond training, what can we do for monitoring, evaluation, supervision, and ongoing level of support. So as of now, that's what we have for the sports end. And for youth, we said that there are lots of programs which we wanted to deep dive. So I'll leave that open for now and think of all the different pathways in which we can engage. But as you will see, this is looking mainly at sports at the moment. It's looking at the connection between physical and mental health. And as you can see, it's mainly around coaches. It's mainly around doing sports as a form of intervention. So we understood through our lots of consultations is that the youth bit is getting left out. So let's see what other programs can be leveraged. So that's what we had on that strategic priority around intersectoral collaboration. This one is relatively straightforward, the strengthening the mental health information system. Very briefly, we recognize that there is a more standardized protocol for physical health, but somehow not for mental health. So the conversations over the past few months have meant that there is now a clear mandate within the, say, the DHS2 system that it also includes mental health indicators, and that process is going to begin soon. So at least we have better data and we can make better interventions. And this one is also looking at suicide surveillance as a specific form of intervention because we know that this is a priority in our country. I don't think I need to get into this bit. Let me move to the last strategic area, which is looking at protecting the rights of persons with mental health conditions. A huge amount of conversation was around people's rights to to do simple everyday activities without being locked up into institutions. So this one is focusing more on, again, we as Grenadians are signatory to the CRPD, and this is part of our mandate for improving mental health services so that people can, have access to services again at primary, at secondary, at tertiary care, at community levels. What kind of access to care do we need to imagine to make sure that people are living on an equal basis with others, that no one is being discriminated against only because they have a mental health condition? So part of the interventions there is, again, looking at what is the evidence, what other programs do we know. So the Quality Rights Program is one such tool that we can use to equip everyone to reduce the human rights violation. Something, again, which is more specific to Grenada is the issue around abandonment by families for people with lived experience, is that many people reported that family abandonment, especially in a psychiatric institute, was quite common, and something needed to be done about that. While it's quite a complicated issue and it requires multiple things that need to get done, something that also came up in the consultations is to focus on families and carers, that are they feeling supported enough to not then lead to abandonment. So that's the part that we're reworking. But essentially, how do we make sure that we're moving towards the path where people don't need to get abandoned, which means how do you increase community integration, inclusion? And that can only happen if it's not just sitting with the Ministry of Mental Health, but with all of us. So that's the broad goal that we had set. The next bit's probably not that relevant for this discussion, but essentially looking at processes for implementation, review, monitoring, and making sure that we're still achieving what we had hoped to. With that, let me then just pause and just check if you had any questions, comments, reflections, and any specific suggestions that you had from your own ministry of what we need to be adding here, changing here, and what opportunities we probably have missed, because there's clearly a lot happening across the different ministries. So yeah, I'll pause there. I have one mic, so anyone wants to start, you can let me know. Or was that too much of information, and do we just need a moment? Yes.
Good afternoon, Vonnie James, Ministry of Youth. I unfortunately was on the scene of a recent suicide a few days ago. And of course, the officers treated the scene as a crime scene. Now, if we're going to speak about changing our statutes so that suicide is not a crime, will that scene become a public health scene? Yeah. And will that affect the way caregivers interact with police? So I just want us to have some discussion against that.
Yeah, very valid. Josh, do you want to respond to that, and then I can comment?
Thank you, Mr. James. I think that's an interesting question, to say the least. I think to some degree, such a scene will have to be handled quite carefully, because perhaps there will still have to be some investigation, and you wouldn't want it to be a scene that is trampled on, because it has to remain as it was met, right? Taking that into consideration, I think it would still need to be handled delicately. But where it comes to additional protocols to be established, that would warrant further conversation with law enforcement, for example. But I still believe that's a very delicate scene. I don't know if that answers your question in part, because I definitely cannot answer it fully.
I think that's totally fair. Part of decriminalizing suicide attempts will mean that we don't rule out mental health or severe stress as a contributing factor for death by suicide. So definitely the scene will change. For some reason, yeah, everywhere suicide has become a subject of criminal investigation rather than health indicators. So the second thing that I'll point us to is that the surveillance system is supposed to be sitting within the health system. To say that this is a health condition, actually it's a multifactorial thing. It's not just health. But we do need to understand what's happening in our country. So the two nods that we're making around it is acknowledging that we need to do the work for decriminalizing suicide. Part of the legislation piece, which we're happy to share the progress that we have made so far and what we've put in it, will be the reading down of the criminality. And ideally, it should not sit, the health indicator should ideally sit outside of the crime statistics. Maybe that's a conversation in progress, and that sits more with the legal jurisdiction, and the policy and plan can only make a mention to say it needs to get done. The second bit is, of course, the conversation should change. In our country as well, even in India, we did a reading down of the decriminalization. Because otherwise, it all becomes a matter of, I don't know, you interacting with the police, whereas you know that actually it was a cry for help, it was depression, it could be just any other relationship issues. So it's a range of issues that we need to address. So the two nods that we made here are looking at that direction, and then there's a whole legislation piece that needs to get implemented to make sure that this is complementary to it. But you're absolutely right. The surveillance system hopefully will generate enough data. We will know what's happening and not just rely on the crime statistics to where it gets kind of confusing between what was a criminal proceeding versus what is a public health concern for us. Yeah.
And additionally, sometimes you have what appears to be a suicide when it's really a murder. All right. So that is important to keep that in context as well. Once it gets to what appears to be a completed suicide, there has to be an investigation. And again, the scene will be treated differently.
Yeah, but that's for deaths, and this is for attempts. So the death bit will always need investigation. Here, I think the indication is of attempts to suicide, which is the criminalized bit. Is it helpful to just have I'll probably share the screen where there is
Okay. The question is in terms of the technical working group.
Yes.
Is it limited to government institutions? Because I've noticed that there's only ministries involved, or can it extend beyond?
What would you mean by beyond?
Non-governmental organizations.
I see. I think as of now, the conversations that we have had is looking at ministries, because there is a bit of like a mandate and expectation that the ministries will do some actions. But as a part to that, there is a different level of conversation around building more advocacy, building more civil society movement. But the technical working group was meant to be more concerted around what activities can we do across our departments, making sure that there's no overlap and we can maximize on what's happening.
Okay. Well, the question was based on because there is the the plan to decentralize, to do more community-based interventions. It might be, well, I was thinking that it could be useful, but I understand the context. But I was thinking that it could be useful to include non-governmental organizations, because we know that there may be the first point of contact may not necessarily be a mainstream system. So that was the thinking, but I understand the institutional arrangements required. Thank you.
No, fair enough. So are there any kind of like, are we just talking about non-profit organizations,
So,
civil
for example,
society
faith-based organizations. So, faith-based organizations, because we know that persons may reach out to the religious leaders in the community as the first point of contact.
Interesting. Okay. Gives me another possible.
I'm just going to piggyback on Mr. Sanbernard's question. When we did have the technical working group, we did include some NGOs. So there was Red Cross, Lions Club, and some other non-governmental organizations.
So any large, so then how do you think the inclusion criteria should be set?
If I recall from the terms of reference, I think it was open to 2 NGOs. I don't recall off my head, but there were specifics in terms of the number of NGOs that would be included on the TWG.
Got it. So suggestion to mix it up, have some process in which the non-profit or outside of the government system can participate. Okay. Thanks.
My question is, would the policy put forward an established pathway for referrals among all of the agencies and will government organizations and external agencies outside of government?
So say a little bit more about that. What kind of referrals are we talking about?
So, no, if we are to establish a central a database for storing our information, we have to ensure that we have a system in place that would feed referral numbers in. So my question is, what accommodations would be made under the policy to ensure that referral information is pulled from the various agencies that provide psychosocial support?
Fair. So essentially, if your data has been collected, which kind of services should you be going to? How do we tap into this information apart it from just sitting with the health and mental health department? Is that then accurate? Fair enough. Maybe we can try and then explore it a bit more. The idea as of now is to say that if you're going to train primary, secondary, tertiary care services, which are health, mental health, if we tap into existing programs that are happening across different ministries, then people will have many pathways to enter the system. So the idea of the decentralization would be saying that now, technically, if you're part of the community, anyone you interact with should have some bit of information around mental health to say, you should go visit that place or the other place. So there will need to be a lot more training and capacity building to make sure what is everyone's threshold. So at what point in time can I recognize a mental health condition, do some early identification, refer you to the best place possible? And for that, there needs to be some system in place across the primary to tertiary level services. So I suppose we can cull that out a little bit more, if that is your question. Yeah, okay, sure.
Ensuring that there's an established, well, clearly defined pathway for referrals, because sometimes it can get muddled.
Where do you go? Where do you send people? So most specifically, I suppose for youth and sports that you're part of, are there any things that we should be keeping in mind to say someone needs to get trained more effectively to make sure what is that threshold, where should they make the referral, who should they make the referral to? Are there any kind of inputs that you might have there? Like, who in your ecosystem within the ministry do you think needs to get trained to understand what's their threshold and what level of information will they need?
So we have a suggestion
I had just said project officers and field officers. Because they deal with the young persons on a daily basis, they should be trained to be identified as, to know when they should refer somebody to a well venue that could accommodate what is happening at the moment. And I say a well-trained venue or an opportunity because you could do referral at the moment and at that point don't really get what you want out of it. Right? So.
So say a little bit more about the program officers and the project and field officers are based at the community, or are they at the venue? And how do we make sure that there is some outreach?
They are based both at some at the office and the majority is out of the field. So they deal with persons out there on a daily basis.
And is there a specific cohort that they look at? Is it youth of all kind? Is it...
We supposed to be dealing with 18 to 35, but to be honest with you, it's wider than that.
Yeah. You mean earlier and later?
Earlier and later.
Okay, I see. And this is, say, a drop-in center where people come in, or you're just out in the field?
Because we have a variety of projects and programs offered to young persons, that's where we get our scope of persons over there. And we are talking about both male and female, young people general.
Got it. And how many project and field officers are there across Grenada? Just approximately? Plenty.
Plenty. If we look at all our different projects that we offer, officers could be as much as, let's say, 55. So that's a big scope that need to be properly trained to offer service.
Got it. So there can be some scope for collaboration around training and supervision and mentorship and the whole spectrum.
Exactly.
Got it. Okay, that's quite helpful. I'll pass the mic back.
I just wanted to speak to, from where I sit as Public Relations Officer in the Ministry of Social Development, and we now have a total Ministry of Health and Wellness. We need to decide where we should be, because where we need to be is way bigger than we are. And a lot of the alleged suicide, I sometimes don't believe it's just mental health issues. Outside of maybe, as we would have said earlier, it could be instances of homicide and so on. And we need to decide who does what, so we don't double efforts in reaching persons or the services that we offer to persons, because our ministry has a psychosocial unit, and this is the first responders, whether it's a natural disaster, whether it's instances of suicide and so, and we do reach out to persons. So we do not want to duplicate efforts. So we need to have better collaborative efforts as to who does what, because we don't want any issues as to, well, this is our responsibility and no, this is your responsibility. So when we reach in persons, I would want to believe we collaborate our efforts to reach out to persons. right? And we also would like for persons to be able to reach out to us, because I think we have an issue right now. Persons don't really know where to go to or who to go to. There are times when they reach out to religious leaders in their communities, and there are times when they reach out to friends. And another thing is persons take statements lightly, because one of the recent alleged suicide happened in my area. And from what I've been understanding is the young man would have been saying to persons, this is what I'm going to be doing. And he was taken lightly. So we need better efforts as to how we reach persons and what we do to get to where we want to be.
Yeah, that's a valid point. So maybe if I can just nudge you to say, how do you think that collaboration should happen? So if there are already psychosocial providers, where is the scope where we can say, let's maximize the effort? Because you are already training them, you're already making sure that that exists. So how would you want that to be articulated?
So for instance, consultations like these, we need all the stakeholders involved. And as Pastor would have been saying, the police sometimes don't even cooperate. So we need journalists, we need the police, we need the ministries of mental health, we need social development, we need everybody. This is your role, this is my role, but at the same time, we will be working as a team.
So then is it some sort of protocols, or the technical working group can be used to probably develop these protocols to make sure this interdepartment, interministry?
Exactly.
Okay. Okay, great. That is helpful. And for the suicide prevention bit, you're absolutely right. So which is why there's a specific mention of just suicide prevention training and upskilling ourselves to understand how each of us can become gatekeepers to identify early, make sure that we are, again, busting some myths around suicide and making sure that care is available. So point well taken. Yes.
Hi, good afternoon, everyone. I may have missed it, but I just wanted to double check to see if the discussion or the policy has covered, because I know we mentioned collaboration amongst ministries, etc. However, the protective covering for the various ministries that may be assisting or may now have a trust to carry out the responsibilities that would have been outlined. For example, in the Ministry of Youth and Sports, we have our social care unit. Some other ministry may have something similar, but is there a protective mandate that protects the officers who are carrying out this responsibility, that protects them professionally, but also protects the clients as well in terms of the infrastructure? What is required when they're having, let's say, counseling sessions? What type of infrastructure is necessary? What kind of credentials they should have? Let's say we have somebody who is a psychologist, they have a master's, should they be licensed? Should they be associated with the association that is responsible for mental health workers? We have a social worker. Should they be doing counseling? Should they be doing referrals? What is the responsibility, so that we all have that legal protection? And most so importantly, the clients, they have a protection that when they come in and they have a certain expectation that it's met within the prescribed fashion.
Fair. Go on, Josh.
Right. So that's a very good question, and there are some, let's call them pre-existing protections, because, for example, the allied health professionals. Is it a unit? It's a council, right? The Allied Health Professionals Council does, in fact, license master's level counselors. And there are specific guidelines. As a matter of fact, there are you have to satisfy the requirements to be licensed in the first place. So that is already pre-existing. But further, as we're being progressive, beyond the policy, we also have legislation that would highlight the responsibilities of service providers as well as their rights. And then you have the rights of the patients as well, or the persons who need services. So that would be emphasized a bit more in the legislative branch of this program here, this project. But the policy is pretty much an umbrella, so to speak, and we're not going to be dumping too much into it, lest it becomes too cumbersome.
Fair, but that's a fair point. So I think maybe I'll just do a clarification. So when you're saying that the Ministry of Youth has a social care department, what does that really do? If you can describe who does what? Just the social care unit at, yeah.
So at the unit, we provide psychosocial support to our clients. So when we receive referrals, we sit with them, we do an assessment based on what they are presenting with, and we determine what is the best course of action. Generally, we would have persons coming in with various needs, whether it's physical needs or it's emotional. And in that case, then I will go through the therapeutic sessions with them, the counseling sessions with them. So essentially.
Got it.
Yes. And I just wanted to.
Before you move on. So these referrals are coming from where?
Our officers in the field.
So the same project officers that we were speaking about. So you are referring back to the social care.
Yes, the majority of them, but we do receive from external persons outside of our youth programs. We do. To a lesser degree.
And this is publicly available information, so anyone can reach out to the social care department. Or does it only come through a referral?
So the referral can be self-referral, or it can be through our officers in the field.
Got it. And this training for the service providers is done by Ministry of Youth and Sports, or is that being done collaboratively with Ministry of Mental Health or Social Development?
I don't follow the training, sorry.
Who's training the staff? When you make the assessment, how are you getting trained? Who trained you to do this job?
Oh, I'm wondering, like, what?
Yeah.
So I do have a master's degree.
Yeah, but okay, got it.
So I do have a master's degree. I'm a licensed master's level psychologist. So when the referrals come in, we do the intake process, and I sit with them and I do the assessment and go through the counseling process.
Understood. So everyone is pre-trained to do this job. You are not trained on the job, as I understand.
No, it's not on the job.
Except the project officers that we were speaking about, there is some training that happens while you're on the job.
Mm-hmm. So, okay. So the project officers, they are responsible for different communities, constituencies. They will go out and interact and speak with persons about their needs and also let them know what's happening in the ministry. So they're sort of like a bridge. They carry information. But in their interaction with the young persons, somebody might disclose to them that they have certain challenges going on. And in that moment, they can make the referral. And let them know, well, we have a social care unit and these are the services that are provided, and you have access to free services.
Mhm.
So,
So what we were speaking about earlier is the project and field officers
Uh-huh.
could be trained to identify early signs of any
Yes,
distress
yes,
and make the referrals.
yes.
Currently, you're saying that you already do that within your ministry.
So we have had some training,
Okay.
but in this case, it has to be ongoing and a bit more consistent.
Got it.
Yeah.
Got it. Okay. So that is another space where we can collaborate. But I also understand that social development has their own psychosocial counselors who they're also training. So there's no conversation between the social development psychosocial counselors and the trained counselors. No. Okay. It's a different program. I get that.
Yes.
Do you just want to introduce yourself, Samitra? You've come in, so we did a small round of introduction. I know some people are new on that table as well, but go on. You I think you have to use a mic.
Hi, my name is Soumitra Patari. I'm a psychiatrist by training. I'm one of the PAHO consultants, colleague of Jasmine's. The reason I was missing for the first 1 hour is because I had another meeting which PAHO had organized with the Minister of Health in Antigua. So I was online for that. I just finished that and I've joined here just now. So I'm going to listen in because I was not here before. So I'm not going to say anything at the moment. Yeah.
I can summarize a little bit. So we've had conversations around decriminalizing suicide. So how that will change the conversation. We said that there is an effort for decriminalizing and the surveillance system. The second suggestion is in the technical working group, can we get people who are outside of ministries and get some non-profit players, whether that's large NGOs, and apparently that was done earlier as well. Then there's a largish conversation around a referral system. How do we have adequate information across each of our ministries to know who to refer to at what point in time? And then I think here we are at the legal provision. So how do we make sure that anyone who's providing mental health care is also legally protected to provide that level of care? So how I think your question was more around the thresholds that we need to set for each of the service providers to make sure that this is setting expectations clearly about the level of care. And then we find out that there is already a social care and psychosocial care department within youth and sports, which is also there in social development. So there are multiple channels. But the interesting bit, I think what you were saying was the project and field officers in youth and sports are already working with young people directly on the field. So that can be another opportunity for training, referral, and protocols set for supervision and so on. So far, so good. I don't think I missed out on anything. Go on. I think they needed for that. Yeah, it seems they're all okay.
Yeah, just a quick comment really, which I'm sure Josh will agree with, is there seems to actually be a lot of provision for psychosocial counseling, which already exists, but is not necessarily in the Ministry of Mental Health, but is actually in other ministries. And I think really the challenge is going to be how to ensure that all of this provision is acting in concert, if you know what I mean. Like, people are not working independently in silos and one arm doesn't know what the other arm is doing, but to see how that could be added in together so that it all works together, so that you think of it as the entire provision rather than to just think of it as a ministry's provision. You know, you think of it as all of this is available to the community. It's coming from different ministries, but all of it is available to the community. And if we can actually then have some degree of coordination so that it's provided. My worry is you'd otherwise just get duplication and replication of the same things happening, and other things which are needed don't happen. And the second point I wanted to make was, the project officers, as you call them, the people who work in the community with young people. One of the things is they could really be trained, what we call gatekeeper training, as gatekeepers. You know, they could be trained to identify young people who are at high risk either of mental health problems or of suicide risk, and how to then make appropriate referrals, how to encourage those young people and their families to use those referrals, and you could actually expand a whole range of people who are out there who can then identify people. So you're not trying to make them into counselors, but just using them as gatekeepers to identify early, the early identification bit. So that's another thing that we could really be looking at. And then that requires, again, a certain degree of intersectoral working between different ministries, because while Ministry of Youth and Sport has these project officers, the training might have to be provided by the Ministry of Mental Health, because you will not have the expertise to provide that training. And so that kind of joint working will actually benefit both ministries in their mission to ultimately help people.
You've had some reflection on this? No? No? Okay.
Be wrong, but I'm not too sure if I'm clear with the aspect of providing or implementing preventative or awareness method. Most times we act when something happens, when someone gets sick. What are we providing to before? Right? I know you earlier on we had some discussion. You would have outlined some information in regards to schools and teachers, talking or whatever. But I think we need, most times we wait until something happens and we are action. We need something before action, if you understand where I'm coming from.
Fair. So that's the preventive bit. Here you're responding to a problem or a situation, and then you discover that maybe there is a mental health distress or a mental health condition, which is when you're making the referral. And I think the suggestion was that how do we at least leverage what you're already doing? So part of your conversations, how can the training then be strengthened for you to identify better early on and then make referrals? And if the social care department exists, then you make referrals there. Or if any other kind of services are available, we all know which channels to refer to, which I think was your earlier point, which is how do I know where to go? And maybe can there be a information database of what are potential sources for referrals as well? Okay. Yeah.
There's a lot of things you can do for prevention, and I think we should see prevention as a broad intersectoral action that we need to do. So, for example, training children, the HFLE programs. I don't know if you call it HFLE or. So the HFLE needs to very clearly incorporate and be active. I mean, the problem with HFLE in many countries is it doesn't work the way or is not implemented the way it should be. But incorporating mental health preventative actions and modules into HFLE is one example. Training school teachers to identify young children who might be, or young people who might be at risk, and then be able to make appropriate referrals. Training parents, the thing is that you need a license to drive a car, but nobody needs any license to become a parent. And most parents, especially in today's day and age where you have very nuclear families, there's no one else who's going to teach you some of that parenting which you might have in the past learned otherwise. So improving parenting skills on how to deal with young people, especially when they enter adolescence, is something that we need to be looking at. We need to, I'm just giving you 2-3 examples, but I think prevention is something that we need to look at every aspect of it, at every potential opportunity. You can you can think of prevention even when you're looking at, say, training the police, for example. In how can you train the police to be able to better handle mental health emergencies, how to better handle someone who might have a mental health distress, or how to identify somebody who might be in mental health distress. So there are a lot of prevention opportunities. The challenge has always been that most of the resources go to curative services, because people want to see curative services because there's an immediate need. The challenge has been to actually divert some of your resources away from the curative services to preventive services, because that's a longer term investment that you're making. I think that's a big challenge for every country, not just in Grenada. But if we can encourage that, if we can get different sectors to work together and see why prevention plays a role, and not really merely look at it from your sector's perspective. So for example, education saying, why should teachers do this, does not actually solve the problem, because teachers might be best placed to be doing it, and so we should be using them for that preventative activity, because otherwise society as a whole pays a price for it. So I think that's really the challenge of getting that level of intersectoral coordination and working together. And I'm hoping that some of the processes that the ministry is proposing in the policy will provide that opportunity to do that kind of work, which is preventative in nature. The other, prevention is also what we call secondary prevention, which means that once you have identified somebody who has a problem, providing them with immediate care and rehabilitation and recovery is probably something that needs to happen as a secondary prevention to prevent worsening of the condition. So there are many ways to look at prevention, and there are lots of things that we can do for prevention. It's a matter of actually putting some resources into doing that. Everyone talks about prevention, but nobody wants to put resources into prevention because the pressure on resources is towards providing curative services. It's always a challenge when you have that pressure to put all your money into curative services. Curative meaning providing somebody with a treatment because they need it just now. And no country is ever going to have enough money to do everything at 100%. So it becomes a matter of choosing what you can do with what you got.
Just a thought of reflection. Based on all that's being shared, when I think about it, it comes down to professional practice as well. Because, for example, when Ms. Perriman would have asked about the protective measures and so on that exist in these policies, at the end of the day, based on your professional practice, you would know what to share, when to share it, right? So maybe because in our programs, for example, for example, Empower, Ms. John is always asking, what can we do? We have this intake happening of new persons. How can we create something so that they can be cared for in that way, right? So in all of our projects and programs, we attempt to provide some preventative, maybe secondary, because by the time persons get to us, they would have already been fairly mature in the 18 upwards, right? So by the time their cases reach us, it's curative. How can we help in this moment? And it comes down to professional practice. So if this policy can clearly identify where we can go, who needs to do what, that's why I asked the question about the referral, right? So, and also for what I think is very important to ensure that it clearly defines how professionals can be held accountable for the inactions or any action at all that might have caused further damage or hurt to somebody. So that's basically what I'm thinking. Accountability.
Afternoon, everyone. No, I'm listening to the discussion because I came a bit late, but I'm thinking it has to be a multi-sectoral approach and a multifaceted approach. Multi-sectoral because there are various stakeholders involved, as was mentioned. We have the Ministry of Social Development, we have the Ministry of Mental Health, we have the Ministry of Youth and Sports, and there are other stakeholders as well. But multifaceted in terms of we need to have the services provided. A lot was mentioned about prevention, but education and awareness is also very critical. And I've not heard much about that in terms of having an education campaign, because mention was made of persons may not even be aware as to the services provided and who is doing what. Where can they go? But it's not just the fact that you have the services being provided, but persons knowing that they can access the service and they have the confidence that whatever they share, it will stay within that, place. Because I think a lot of it is not that persons don't know that the service exists, but they don't want to share because they're afraid that whatever they share, may go out there. Because just last week I was speaking to someone within my community, and they were making reference to a young man who was dead by suicide not so long ago. And well, the person lives right within the community, and the person was saying, but that should not have happened. It should not have reached that far, because a young man, because they were saying, well, he's working and he has this and he has that. Why did he, do something like that? But sometimes he may not have shared certain things with certain persons, because even if you're going through, certain things, you're not willing to share, because you're afraid that if you share whatever you're going through, then, it may end up wherever, and there is that confidentiality issue that we tend to speak about, or we don't speak about it, but it exists, and it is a deterrent sometimes for persons to speak to, whether it is a family or a friend or whoever. And we keep saying, yes, go ahead and speak to family, speak to friends, speak to this person, but it's just not happening. We just keep hearing it over and over that, look, we have this death by suicide. So what are we doing to not just provide the support to them, but give persons the confidence that, yes, you can go and access the support. And when you access it, you would get the help that you need, and only those who really need to know would know. I think that is the missing point in my view, as to where a lot of persons are not coming forward, even if the support is there. I just thought I should share that.
So I'm in agreement with what was shared, because in Grenada, one of the very important campaigns that we need to conduct, which was addressed in your presentation, is campaigns to reduce stigma and discrimination. And unless we come up with a plan to adequately address the stigma and discrimination, of course, it's going to affect help-seeking behavior. And how can we, even as mental health professionals, or just professionals generally, how can we change our mindsets from being very reactionary to doing strong preventative work? That a lot of our programs are focused on prevention. I know even with us, I know the resources are scarce, but if we're able to shift our mindsets to see the importance of prevention, then we are going to make a huge headway in just the mental health field. And when we're doing that, how can we see mental health as womb to tomb? That if we're doing prevention, we're talking prevention from the mother who is pregnant, teaching her how to manage stress, how to manage anxiety, preparing her for life with a newborn, right to the end of someone who is elderly and who's preparing for death and dying. And if we're able to do that, then I can see us making some headway together with collaborating as different ministries. I'm just interested in terms of the community-based mental health services. How can we as different ministries strengthen that in terms of what's already offered? So social development does offer psychosocial support in different communities. The more, in some cases, the more the better, that I can say, okay, social development does this, Ministry of Mental Health does this, and people have options. But at the same time, we also have to ensure that we're all working together, and we're working together to achieve the same outcomes, and we're not competing. So I don't know what the plan is for Ministry of Mental Health. I really...
So that's a good question. I think the plan for the Ministry of Mental Health has already begun to be operationalized in the sense that we have strengthened our community outreach. It's no longer just a mental health clinic monthly, but we have a team from the hospital that is actually meeting with patients outside of the clinic, whether they are non-compliant or they are unable, they have mobility issues and they're unable to attend the clinic. But here, we are dealing with persons who require psychiatric care, right? And so the issue is when we bring everyone together, we need to understand how we all can play a role, because going out to the community just to treat people who need psychiatric care is not enough. We need to meet people at all levels of this, what we call the mental health pyramid. Even, when we talk about prevention, I think, Sumitra mentioned it earlier, that early intervention is prevention in the sense that what are we preventing? We're preventing complications. We're preventing people from having psychiatric emergencies or worse, being hospitalized. So I think the conversation has to inform what levels of this pyramid. It would be useful to even show the pyramid at some point, Sumitra, because I think it would give us a visual of how this works. Someone may have an issue. For example, there's a dispute at home, enough to cause some psychological symptoms, so to speak. If intervention happens then and there, then we have prevented further issues. And so how does social development, that's what we have to flesh out. That's why your feedback is important. How does social development fit in? How does youth and sport fit in? Because where mental health fits in for now is really at the tip of the pyramid where people actually need to be medicated because they're mentally ill, which is a small percentage of the population anyway. In fact, the people who have mental health diagnoses, they tend to be a smaller percentage, but everyone else would, most of the population will be found within that range of persons who are having psychological issues or even a bit more complicated issues. That is, how does social development, or where does social development fit in? Where does youth and sports fit in? We literally have to flesh out a framework to ensure that we get this right. Because mental health, if we count on what mental health is doing, we are really treating people who are mentally ill, right? And before people get to that point, we need to treat them along the way, which is not the sole responsibility of the Ministry of Mental Health, because we are already involved in one way or another. But how can we bring this all together in a concerted approach? I think that is what this engagement is all about.
The technical working group is indeed a good start. The conversations definitely need to be had, should have been had some time ago. But if we were to start from the technical working group, at least we're starting something that we know where we stand. Each department knows what their duties and responsibilities are, and it's clear. And we're also setting referral pathways clear. We're setting avenues for collaboration, and we're recognizing that while we do have different roles and responsibilities, but we're all working towards the same goal, and our mission is the same. And if we can get that started, then that would be a very good start.
Okay, yeah. So, Mr. Hector, just for clarity, because you mentioned what the Ministry of Mental Health is doing is really treating patients, right? And we know that is being done. But what is the plan of the ministry? Is it to stay with that or to expand the services and then to complement what other ministries are doing, like the Ministry of Social Development and Ministry of Youth and Sports? It is just the thinking to continue along that path and allow other stakeholders to do along the way, as you say. I needed clarity. No, I needed clarity on that.
That's a good question. And the reason, and that's a good question, PS. Now, here's the when this is all said and done, we want to ensure, for example, that it's quite beautiful that we have these different ministries, because it means that one ministry is not responsible for everything. And that being the case, perhaps the ministries can remain responsible for what they're doing, but we are going to be doing it being together. So that's the difference, because yes, we will continue to, of course, treat persons who need psychiatric care. It is not that the ministry itself would need to expand its services, because there are already expanded services. It's very important to just bridge a gap between all these services so that we are working together and not in isolation as we have been for years.
Okay, right. So I don't know if what I would say would make any sense, but I will try. From a Ministry of Mental Health perspective, as PS alluded to earlier, it has to be an interdisciplinary approach or intersectorial approach, whichever one you want to call it. So what we at the ministry is currently trying to do is to develop the framework for the integration of mental health services into primary care. And this is where all of the different components that we speak of now, Ministry of Youth, Ministry of Social Development, Housing, whoever it is that has a stake in mental well-being, would come into play. To date, we can't tell you exactly where A is going to be and B is going to be and what the functions are, because we are still working with that or with PAHO. So when that is completed and we develop that roadmap, then we will come back to you, to the technical working group, and present how we're going to go about this. This is the roadmap, and this is how everyone fits into the whole picture, because we know that we have to work together. All of the services that it relates to mental health have to come together to bridge that gap that currently exists. And how it's going to start is not by treating persons when they reach to be treated, but we have to start from the primary care level, and this is where you fit in, because you spoke to the empowerment group, yes, for some empowerment. If you think about it, maybe the persons coming into a program like that may need to have some sort of psychological screening before they began the program. Yes? So when maybe mental health has to do the screening, somebody, I don't know who, as we develop, we would know who exactly plays that role. But if we does that screening, since these persons coming in, it would tell you where they're at, maybe their ability to cope, where different things, so that this particular student, you have to work extra with them on A, or maybe they need housing, because that is the contributing factor really to their mental problem. But when you do those evaluation then it prevents us from going into this deep state of depression, suicide results, this sort of thing. So give us a minute to finish the actual plan for the integration, and we will come back to you to tell you how this whole process is going to roll out. P.S. I'm not sure if I answer you.
If I can just add a little bit more to that, I think I think you've covered everything what I would have thought needed to be covered. And as you said correctly, that it's the way I look at it is that the Ministry of Mental Health needs to provide stewardship in a sense, but does not necessarily do everything from 1 to 100 itself. But it actually kind of takes that overview and says, okay, we need 1 to 100, now who's doing which bits and which are the missing bits and how can we develop that? Really, so that's really in a way that it needs to play the role of almost like a first among equals, like a captain of the team, as opposed to just saying, I'm going to do everything, and that's not going to work anyway. And makes no sense when there might be somebody else who's better placed to do that than the Ministry of Mental Health might be. So I would imagine that that's how, and that's how it'll make a lot of sense. The other issue is that, everybody's understanding of the word community, the word mental health is so varied. What we understand by mental health, what we understand by community also varies so much that sometimes even getting agreement on what we can agree as a common idea of what is called community mental health. I mean, look, there are so many places you can think of community mental health, and I'll give you a couple of examples which probably don't come to your mind first off. New York has this wonderful program which they set up, which is that they trained hairdressers in basic counseling and therapy skills, because they said women go and spend hours with hairdressers and they probably tell their hairdresser everything that they never tell their doctor. Yeah. And so they actually said, okay, so these hairdressers are otherwise just randomly giving advice. Why don't we train them to be able to do very basic counseling stuff? Okay. And that's an excellent program. Okay, it works well, and interestingly, it works very well in the black communities in New York, and also with men. What happens with men is they talk to the barbers a lot. They won't talk to their wife, but they talk to their barbers. So what I'm trying to say is, you can think of mental health in even a place like at a hairdresser. In India, there is this wonderful program which they're doing now, which is training, they have cricket coaches. Young kids go to play cricket. It's a big thing. And I'm out here, probably athletics is such a big thing. But they train these coaches in very basic counseling stuff. So they know how to do active listening, problem solving, behavior activation, very basic counseling skills that you train the coaches to actually do it. So what I'm trying to tell you is that you can think of community mental health at anywhere, starting from hairdressers to coaches to other places, wherever there is an opportunity that you can get. And so it doesn't always have to be formally trained, formal mental health. The idea that everyone who provides counseling should have a master's in clinical psychology is not what you need. Many people don't need that. Many people do need that. It's a bit like if you have a cough and cold, you don't need to see a chest specialist. You probably need some of your grandmother's remedies and it'll get better. You know what I mean? But if you have pneumonia, of course you should be going to the chest specialist. And we need to be able to provide all of that range of services and not just say that, everyone should go to the best possible person, which means they should go to the chest specialist. I mean, it'll just become an unworkable system. So we should really be setting up this kind of stepped care approach, at different levels. You offer people different service according to need, and use a whole range of service providers. I mean, a hairdresser can also be a mental health service provider. A football coach can be a mental health service provider. A music teacher can do the same thing. Places where you can get a lot of people, go to them, talk to them, they have some trust. Those are the places you want to really, there's also a program I know which is working with social media influencers, because young people listen to social media influencers, and getting them to actually talk about mental health in a more positive manner. So there are lots of innovative, low-cost scalable, sustainable solutions that you can incorporate without requiring highly trained mental health resources, which not just Grenada, nobody in the world has them. Okay, no country has enough of those mental health resources. So maybe that's what we should be really looking at.
We actually had a recommendation from social development. I think the juvenile officer usually recommend participants for our program, and sometimes they come in the program with so much issues and we don't know how to deal with it. So I think the collaboration is it's a good thing. Also, one of the ways that we can collaborate within the Ministry of Youth and Sports, we can utilize the youth parliamentarian when they have the debates and so one of the teams could be on mental health and suicide prevention. So that's one of the recommendations.
If we are talking about children and mental health, I think it might just be best to add a protocol to CPA, to Child Protection Authority, for them to handle that, because they do handle issue of children currently. That's still social development, yes. So that's Child Protection Authority. This is under the Ministry of Social Development.
I'm trying to recall when you're looking at vulnerable populations, did we leave that for the Mental Health Act, or did we?
It hasn't. There isn't a section in the policy on vulnerable population. See, okay. Let me tell you what my problem has been with trying to do the policy and the plan, which is okay. Let me tell you what has been a challenge for us when we do the policy and the plan. The way I'm trained to think, the way I'm trained to think about it is, you have a policy, you have a plan, and then you have a strategy. And a lot of the questions that are coming through are bits that I would normally say, oh yeah, that should go into a strategy. So like, while you would mention the fact that for, vulnerable groups need to be addressed, then you want to actually ensure there's a strategy to address those vulnerable groups and then identify which they are. So for me, the challenge has been, how do we write a policy and a plan without it having elements of strategy into it? You know what I mean? Like trying to keep it to a policy and a plan at that level, and allowing the strategy to be developed by all of the stakeholders as they go along. Because I also have a feeling that what might have to happen is that you will need an intersectoral strategy, which means the group, that committee that we are talking of, the interministerial committee, will probably have to get together and actually say, okay, this is the strategy of how we are going to convert this policy objectives and the plan into actual action on the ground. And I don't want to preempt that by saying, oh, well, you're going to do that. And then they say, but who told you? We never agreed to do that. That's my only concern. I don't know if I'm answering your question. You know what I mean? It's it's the challenge between too much detailing versus no detailing at all, and how do we hit that right spot which identifies areas that need to be acted upon, but doesn't try to detail it to the level where everyone else feels that, oh, we are now hamstrung with what is there and we would rather do it differently, but we can't do it differently. I don't know if that...
I asked a question because she mentioned Child Protection Authority, and if we're looking at child abuse victims, but we also want to ensure persons with disabilities. We want to make sure that the policy covers.
If you leave out somebody, then everyone says, well, you must have thought about it.
Okay. Thank you.
Something is just reflecting. I know in the presentation you outlined that families sometimes don't, when they have a mental patient, they really don't really want them back and we create homelessness. But I want to ask mental health, when that do occur, since the patient start getting service from you, do you have that kind of support for the family? Do you reach out? Do you have this conversation? Okay, the person will be coming back into society, how you could deal with them, what signs you could look out for so that you could communicate with us to have this early treatment and, this kind of thing. I just want to have that kind of clarity. Does that happen now? Or are we putting it into policy to happen? Or is it happening? What's really happening when it comes to family support for these mental health patients?
All right. So currently, what is happening within mental health is, in the case of abandonment of persons, we currently have over 50 senior citizens, we would say, because these persons have been residing up at Mungay Hospital over, you would say 50. If Mungay Hospital is 50 years old, they have been there within that time. So we are currently making some provisions to transition these persons from active mental health care into more of an elderly sort of care within the hospital compound. Beyond that, as I said to you earlier, we are now working with PAHO to develop the roadmap as it relates to integrating services, and also that form part of the integration plan. The transitions of persons from within institutional-based care back into society. This has to be a phased approach because we know we still have a high level of discrimination, stigmatization of persons with mental health illnesses. So we have to do a lot of public awareness, public education in order to be able to sensitize the public on how to respond, how to be able to deal with these persons, and not when these persons come back into society, if they only see them by the pipe stand and they touch the pipe, somebody will call the police and say they're acting up or they're behaving in a particular way and they have to be institutionalized. So it's a lot of preparatory work has to go into that aspect of getting persons to be to go back into society. It's going to take a whole multi-sectorial approach, and that is where we would need the Ministry of Social Development and all the other ministries, the police and so, to collaborate with us to get that done. But as I say, all of that is part of the integration plan for mental health services into primary health care. So it's not finalized as yet, so I can't give you anything tangible on it, but as that plan finalizes and we are able to roll it out, we will come to you again to help in executing, implementing that aspect of the plan. I hope I provide some sort of clarity.
Okay. Do you provide family support? That was your, okay. Basically, that's your question, that do you actually get families ready to get people back from the hospital and all of that stuff?
Yes, we do. But importantly, the education component we have to pay critical attention to that, because some families, even when they are called, they don't want to show up. They would rather stay away, right? And that's an issue we have, which is why some people end up being abandoned. But for the families who actually answer the calls and show up, they receive the guidance, the coaching, they receive the support that is necessary to ensure that once that person is discharged, they can support the family member who had an illness that required hospitalization. So it does happen, in fact. But again, what we do need is for more families to come on board, because we've actually seen it work wonders when families show up to support their loved ones.
Thank you. One of the things that, since you brought up the issue of families, is families don't just need support in the way that you are talking of support, which is either emotional support or psychosocial support, but actually families also need practical support. Having somebody with a chronic, severe mental illness for a long time living in the family is a huge burden in many ways. The burden of caring, and not just the burden of caring, but the financial burden of caring, which is so huge. I mean, many families end up abandoning relatives not because they do it out of choice, but because they just can't afford to anymore. The cost of caring becomes so much in terms of just purely finances that families can't afford to. And I think I think instead of just looking at it as families are uncaring and don't care, I don't think that they're uncaring. Sometimes even if they want to care, they can't afford to care because there's too much of cost associated. I mean, if you got someone with a severe mental illness at home, then you're really looking at least one person in the family who can't go out and work, for example, because they have to stay back and look after them. And nobody's paying for that. And somehow, and so I think when we are looking at families, not only should we be looking at this kind of support, which is the psychosocial support, but actually looking at government, looking at even providing financial support, So in some countries, for example, you get a caregiver allowance, if you're caring for someone with a long-term mental health problem, let's say, or a child with a developmental disability, then the government gives you a caregiver allowance, which is partly acknowledging the fact that if you didn't stay at home and look after this person, it would cost the government 10 times more to look after that person in an institutional setting, So I think when we look at families, we should also be looking at that kind of support, or sometimes families need some different kind of support. I've heard, for example, I've heard, in other countries, I've heard families say things like, well, I should be allowed at least a few extra days of compassionate leave, for example, because I'm really struggling looking after someone at home and trying to hold on to a job. Can I not get couple of extra days of compassionate leave in a month because this person now needs to go into hospital or has to go and see a doctor, and if I don't take them, they're not going to go. So, there are lots of ways you can help families in practical ways. And I think frequently families want practical support, not counseling. They would rather get that practical support. And if they got that, then they say, fine, I'll be fine. I can look after myself. But we always think of support as providing a counseling session, and they'll say, I don't need the counseling session. I mean, I don't have the money just now. How are you going to solve my money problem with the counseling session? So yeah. Yeah.
With the brother or the sister. Now they come back. They feel that they cannot stay. So we provide housing, something to add on to that, to give a space for that person. And that's why I say the answer was just fast, because it's wider than that.
And this points directly to the reason why we are all in this room. Because it's one pie, but I'm sure you could easily see which angle your ministry is going to be biting from, right? And so, so it's, right? But really and truly, we do have to split it up. We have to share it, and we have to manage the process, right? Which is what the role of the Ministry of Mental Health is here. Do we have more comments, additions, questions? Let's take a break. Maybe when you come back, you'll have some more questions. Let's just take a quick break. We have some refreshments at the back.
I don't want to disturb what you're eating, but I just thought it's been a long afternoon, and I just wanted to ask you if people have any more points. As Josh said, once you had your coffee and your break, maybe you wanted to make some more points, or if not, then we could actually close the meeting. I mean, that doesn't stop you from sitting back and having your tea and coffee and drinks, but I just thought, is there something else that you wanted to raise or bring up or highlight, or something that you want us to keep in mind when we are finalizing this policy and plan draft? Anything at all, this is your chance.
So the working group, would it be legislative or would it be in the policy? In the policy. Okay, so that persons would be aware, look, this is an approved policy and they are responsible for, okay.
Yeah, we were putting it in the policy so that it would have some kind of sanctity to the whole process.
Okay. In terms of financing the policy, I remember there was a 10% designated allocation. That is a recommendation. Yes. Is it 10% of GDP, or is it of health, of mental, right? Or 10% of the health budget? Because that's what. Because right. So is that? Do you see that? Going into the policy, do we see any resistance? Do you anticipate resistance, or do you think it's going to go through? Based on the feedback.
That 10% recommendation comes from the fact that at the PAHO meeting, the health ministers in the Caribbean made a commitment of saying 10% of the health budget will go for mental health. Okay, so that's a ministerial commitment made by all the ministers in the Caribbean at the PAHO meeting. So we are just putting what ministers and governments have committed, not anything new.
Based on the 10% agreement, Grenada is very unique. Remember, Grenada has now ministry designated for mental health, unlike the other islands where they have a Ministry of Health and part of their annual budget goes towards mental health services. Grenada has a designated ministry, so I think we already we can boast that we maybe achieve that goal.
So what we are putting in there is Is that better now? Yeah. So it's not a new commitment, but that's where so the 10% comes from there. It's not just a number we plucked out of the air. You know, it comes from the PAHO commitment.
So my question is, with the 10%, would that be, so let's say for instance, as she made the unique point that mental health is, they're separate. So let's say mental health gets a 10%. Would it be 10% for mental health, or would it be spread across all the different ministries responsible for MHPSS? So if social development needs something, can we tap into Ministry of Mental Health and say we need support for that?
Okay, let me try and answer that very well, because I think this is always what happens. I think these commitments are made at the government level. Okay, so this is when government, this is not the Ministry of Mental Health or Ministry of Health per se. The commitment is that when the government says that, the government of Grenada commits to spending 10% of its health budget on mental health, what would happen is, and this is how all governments work, is they would say, okay, where all are we spending on mental health? We are probably spending on mental health through the Ministry of Health, the Ministry of Mental Health. We are spending on mental health through the Ministry of Health probably. We are also spending on mental health through Ministry of Social Development. So they will add it all up and add up the total and say, look, this is how much we are spending and this equates to 10% of the health budget. That's how they will look at it. So it's not going to be the other way around that you would suggest that, oh, now can we get some money from them? That's not. But P.S., you agree with? I mean, that's how they calculate it. Yeah.
That has that responsibility. So, for example, the resources allocated for youth would not necessarily be under the Ministry of Youth and Sports only. We have for youth under agriculture, because we have the Youth in Agriculture program. You'll look on the Ministry of Education and you'll find other initiatives as well. So when you're talking about whether it is agriculture or for youth, then you could go under all of the various ministries where you have the resources to say, well, look, this is what we have budgeted. So yes, that is correct.
Yeah, that's how I understood the calculations are done. It's not going to be, it's not unfortunately going to be where you could go to Ministry of Mental Health and ask for.
Just checking ministries, even now, we do collaborate to do different activities. And if social development is doing something with some sort of psychosocial support because is Miss Matthews speaking, so I'm gathering she's speaking from that end. And support is needed from the Ministry of Mental Health, you can reach out. If we can assist, we assist. It's a whole of government. So even now, whatever you're doing, and that would help us too to know what is happening in the other areas and see how we can learn. Maybe at this point in time, we may not be able to support it, but in future, we can, budget for those other things. So collaboration, communication, speak to us and, we'll see how we can support those areas even now.
No, I just want to make the point that what she said is important, because for the purposes of budgeting, when you have your plan, you need to know where the resources are for the various initiatives in the plan. So some of it might be under our ministry, some of it might be under social development, some of it might be under the ministry itself. So I think it is important, so for the purposes of budgeting, that there be that discussion once we reach to that level to ascertain where the resources will be allocated. And that you're clear, and you don't have initiatives and it is not budgeted for at all, or you have duplication of efforts in terms of, duplication of resources, I should say, in the budget. So I think it is important to highlight that there needs to be that coordination in terms of the budgetary allocation.
Having the intersectoral coordinating committee is probably the place where you can have these discussions. He asked the question on 10% and then he's disappeared. Where did he started the and then he's disappeared. Okay, thank you all so much. I don't think there are any more questions. Thank you all for coming, and thank you for all the suggestions and the constructive engagement in addressing these issues. I'm very sure we'll come back to you with, there will be some process that the ministry will engage once they have a final draft. But just before we close off, I'm just going to ask Josh if he wants to make any remarks, final remarks or closing comments, or, it just feels that the ministry should be doing it, not me.
All right, so thank you everyone for showing up. I was told that the time was kind of strange, but you showed up. Thank you for being here and for your comments, for your feedback. This is not the end, because we will be in touch as we progress. As a matter of fact, when the mental health policy is finalized, That's really when the work begins. And so your participation here really communicates that you will be along for the ride as well as we begin to work to implement the policy. Thank you for showing up. Thank you for all that you've contributed. And good afternoon to you. On behalf of the Ministry of Mental Health, Wellness and Religious Affairs, we thank you so much. Yes. Yes. So on the 22nd of June, we'll be launching a suicide prevention hotline, which is it's much needed. We have volunteers lined up to respond to the calls and messages. And of course, the volunteers are not going to be doing extended therapy sessions. It's really just psychological first aid, right? We know that suicidality is one of those issues. Quite often, a distraction causes a person to change their mind. And so if we have people who can intervene at that level, and once persons know they can make a call, of course, we have to ensure that we educate the public as much as possible so they do not misuse the hotline or attempt to do so, because we don't want that being clogged up as well with, I don't want to say unnecessary calls, but calls that are not appropriate for the hotline. So June 22nd is when it will be launched. And we definitely look forward to this, especially at a time like now where we see what has been happening. We want to ensure that people can, if they feel all alone, at least they have a number that they can call, and it's not going to cost them anything to dial, right? So you can call whether or not you have credit. Yes.
We are in the hurricane season. Are we going to wait for the mental health policy to be implemented, or are you as a director going to take the lead to start a technical working group? So if needs be, and we do have to respond in the case of a disaster as what happened in Hurricane Beryl, that we are going to be better organized?
That's a very, very good question. Thank you for that. We are actually not going to wait for the hurricane season. Oh, we're in the hurricane season? Sorry. So what we have been doing is we've been training. We've been doing a lot of disaster mental health training, and we saw that we saw the fruits of that pay off so far. But you're very right, Ms. Matthew Clarence. We need to, as it is here and now, truth be told, we got caught this year again. But the issue, I think, is that we're also moving away from just a MHPSS technical working group, because what we came to recognize is that with that technical working group, we were very disaster focused. So we took, I guess, a broader approach so that the group responsible for managing the mental health policy as well, right? Which would, actually, if you look at the composition of the group for managing the mental health policy, you'd notice that it looks exactly as the technical working group for MHPSS. And so we have to begin pronto. We don't want it to be disaster focused.
You know, I think your question is quite appropriate. Why would you wait for the policy to be approved to set up the inter-ministerial working group? Why don't you do it tomorrow morning? I mean, that's the question. And I think that's a very appropriate question. But as PS also mentioned, you know what's going to happen. My worry what's going to happen is if you set up this inter-ministerial group now before the policy has got a cabinet approval, is that it'll just be seen as something that the Ministry of Mental Health has set up and may not necessarily get taken that seriously by every other ministry. Once it actually becomes part of an approved policy from the cabinet, then it will have that sanctity and structural there'll be a systematic provision that has been made, which will probably drive the process forward. So I'm sure it can be done right now also, but I doubt it will function that well as it would when you do it after the policy is approved by the cabinet. Would you agree with that? Or, I mean, since you had also brought up the same question.
It depends on the individual, because you see, the thing about it is, I don't want to say yes or no. The thing is, persons have their own priorities, and what you may find happening is that they may not be able to attend a meeting when you convene it because they have their own priorities. But I think if persons are dedicated and committed to the cause, they will make themselves available even in the absence of a cabinet approved policy. So I don't think the ministry should wait on the approved policy. I think the ministry can go ahead. You may not get everybody in attendance at the same time, but you can move forward, and then the cabinet will then have the approval thereafter. That would be my recommendation.
So maybe this is something the ministry can discuss internally and take forward.
Okay. Duly noted. All right. Any more comments or questions, queries? Well, actually, should we take questions now? Who said no? All right, so no questions, no questions. Folks, enjoy the rest of your evening, and thank you so much for being here with us. Give yourselves a round of applause. All right.